men and women working together. Entire communities, young and old, participating, devising their own solutions to make lasting changes in hygiene and sanitation. Changes which have resulted in improved community health. What is making this difference? A new approach called PHAST. PHAST is an acronym for Participatory Hygiene and Sanitation Transformation. Pilot tested in 5 African nations, it's not business as usual. What is PHAST? It's a participatory method used with communities to improve hygiene and manage their own water and sanitation. The underlying principle of PHAST is that to make a permanent change in hygiene behavior, people must understand for themselves the cause of disease and how it is transmitted. And they need to believe they have the power to do something about it. 80% of diseases in developing countries are caused by poor sanitation and inadequate water supply. 900 million bouts of disease a year. We know how to prevent these preventable diseases, yet they continue. Health education efforts abound, but often without lasting success. But PHAST is different.
When we are now using PHAST, it is the people who identify their own problems after having been provoked by the PHAST methodology of teaching.
Unlike the traditional top-down approach used in educating communities, the PHAST participatory activities are tailored to each community. The community decides what needs to be done, who will do it, and when. It acknowledges that communities know more than outsiders usually give them credit for. The days of talking down to people and driving off, leaving a trail of dust, are coming to an end. As one 84-year-old woman declared, "All my life, people have been coming here, telling us what to do. This is the first time anyone ever listened to what we think." Before introducing PHAST, community extension workers are trained in sessions such as this. The training is based on participatory learning principles, the same ones they will be applying at the community level. Local adaptation and innovation is not just encouraged, it is essential. The role of the extension worker under the PHAST approach is now facilitator and trainer.
We are now on demand as extension workers. People are coming in dozens for our help.
Along with local artists, they create the important graphic materials, the toolkits used by the community. These tools reflect local knowledge, customs, and environment. Because these tools build on one another and are tailored to each community, they enable the residents to define their problems and develop locally appropriate solutions. Among the tools used to involve the community mapping, 3-pile sorting, transmission routes, the pocket chart, and the sanitation ladder. Community mapping is often the entry points for involving the local residents, who, using available materials, together draw a picture or map of the community. These maps take many forms, from twigs and rocks to paper cutouts. The maps show sources of water and locations of sanitation facilities. They also identify environmental problems, such as open refuse and poor drainage. Building on the knowledge of the local residents, the map helps them visualize the overall situation and help decide what needs to be done. Where should they put the next water point? Who will maintain it? Should they build more latrines, and where? Three-pile sorting is a tool that stimulates a lively discussion about common hygiene practices and their impact on health. Participants sort pictures of different activities into 3 different piles: good, bad, and in between. This tool helps reveal the depth of local health-related knowledge and stimulates discussion about what is appropriate and what isn't. Transmission routes, another tool, helps communities understand how disease is transmitted through fecal-oral contamination. The pictures help to increase knowledge of diarrheal disease and encourages discussion of what behaviors are putting people at risk for infection. This leads to the follow-up exercise of how to implement barriers that can block disease transmission, such as hand washing, boiling water, and using latrines. Also in the toolkit is the pocket chart, which is used to tabulate how often and where people defecate, and where and when people collect water. Residents place their markers in the appropriate pockets. Once totaled, the group discusses whether actual practices are good or bad. It can also be used to compare information over time. The sanitation ladder, a set of posters developed with local artists, is another tool. In this exercise, participants arrange the sanitation options in a ladder, from using no latrine at one extreme to a flush toilet at the other. Young and old in this urban community identify their current situation and where they'd like to be in the future, as well as attitudes and behaviors that may be obstacles to improvement. Using gender role analysis, PHAST raises the awareness and understanding of gender inequalities. The roles of men and women are discussed, and from these findings, communities map their way forward.
I was amazed by seeing women holding trowels and spirit levels, a thing which I had never experienced in my life.
In the FAST pilot program, success has been evident in all regions. We take a look at results in Kenya and Zimbabwe. In 6 pilot districts in Kenya, communities decided to form health committees to determine their priorities for disease prevention. These committees decided to conduct house-to-house hygiene education to promote proper handling and storage of water and food, hand washing after using latrines, building hand washing facilities, and cleaning up the community environment. Community leaders asked public health officials for technical information on latrine building and protection of water sources. The health committees coordinated plans for latrine building, and their latrine coverage increased. They also asked for FAST tools to use in schools. They recognized that students were important agents of change in their families.
What do you think would happen if she leaves the mandazis uncovered?
Before the end of the pilot phase in Kenya, the FAST method had spread to 4 new villages. Because of the success of FAST in rural areas, the approach is now being adapted and applied in an urban setting. Although most of the urban residents are tenants, the need for everybody's participation in improving environmental conditions is the same. 3 pilot districts in Zimbabwe were selected. The FAST method was used in tandem with a program to upgrade family wells, and with another program of school-based health and hygiene. One community submitted its own reports to the government about their water and sanitation situation. They had decided what they wanted to do and asked for technical assistance to do it. In another community, in the space of 8 months, 24 unfinished latrines were completed and 18 family wells were upgraded.
It has worked so well that we had to move forward to more than just restricting it to talking about sanitation. Now you find in this province we've got pictures dealing with malaria, pictures dealing with the TB. The whole thing is expanding from FAST.
FAST is working.
We have tried to involve the people, and in doing so, we think that the achievements have been very positive.
FAST is mobilizing communities. Pilot tested in 26 districts with over 1,000 extension workers trained and more than 20,000 community members taking part, extension workers have experienced an enthusiastic response from the communities, and health workers are seeing the impact. FAST has made a difference. While FAST requires budget shifts, new training methods and materials, it gets results. FAST methods empower communities to develop and manage their own solutions. The outcome? Better health and healthier communities through sustained improvements in hygiene practices and water and sanitation.